We're going to switch now to a presentation from Dr. Reaume, and he is an undergraduate Bachelor of Science from Queen's University, and then did medical school at the University of Ottawa in 1994, which doesn't seem possible. You don't quite look old enough to be graduating then. Did internal medicine training at Dalhousie University in Halifax, Nova Scotia, and then a medical oncology fellowship at the University of Ottawa. So we've got some guys who like to come back to Ottawa. These are hometown boys, I think. Masters of Science was completed in clinical epidemiology at the University of Ottawa, and he is now the staff medical oncologist at the Ottawa Hospital Cancer Centre since 2001. Dr. Reaume's practice is in lung and genitourinary cancers, and he is currently the director of the University of Ottawa Postgraduate Medical Oncology Residency Training Program, again another long tongue twister, and a member of the National Cancer Institute of Canada's Committee on Economic Analysis. So we welcome you and look forward to hearing your presentation.
Well, it's a little daunting after those two great talks to have to come up here and give a talk. And Kidney Cancer Canada is an amazing organization. You're very lucky to have it. It's one of the most best organizations for advocating I've seen. And Deb and Tony did a fantastic job. And sorry, Deb, unfortunately your commentary is blocked out by my presentation. So we'll see your comments at the end. And but the most daunting thing is I think my kids might be watching at home. So hello, Veronica and Evan, if you're online there. Anyhow, so as Rodney said, I'm going to talk about more advanced disease and the treatment options that have come out. So I titled it, Where Are We? So I don't have any pictures like Dr. Bro did. But the slides do move around a little bit, so I apologize. Just close your eyes if I get it moving too much. So let's just get this moving along here. So we always disclose if we've, at the beginning of all our talks at the university, if we've received honoraria. So I have done some advising for 3 of the companies that produce drugs in the talk, but so there's no favoritism because all 3 I've done some advising for. The objectives of my talk are first to summarize the evidence or the best available treatment options for metastatic renal cell carcinoma. Then I'm going to describe some current issues around both drug access and clinical trials here at the Ottawa Hospital or in Ontario. And then I'm going to update you on some future directions that we're going with our treatments. So let's just give a little background. As Rodney said, kidney cancers, there are benign tumors and there are malignant tumors. And so there are many different types out there. These are the most common ones I've listed here. And the one that this talk will mainly be focused around, and most of the treatments have been geared toward, is the clear cell carcinoma, the most common. Okay. And as Dr. Bro said, when we get a tumor and we get a patient with a tumor and we diagnose the tumor, we then go on to stage the patient to try to figure out where the cancer is and what their prognosis will be with this cancer and what the best treatment for them is. And a lot of that is based on the size of the tumor. So you can see here they've given some reference things. So a plum would be about, a lime would be about 5 centimeters in size. And so for kidney cancer, a lot of the stages 1, 2, and 3 are initially diagnosed based just on size, and they're localized. Now, when you start getting up into 3 and 4, then you start looking into things, has it spread outside the kidney? Is it contiguous spread outside the kidney versus has it spread through the bloodstream or to the lymph nodes? And that's where most of my talk will be based on cancers that have already spread. So where are we? My kids would give me this answer, you are here. And it's not a bad answer because the way I'm going to structure my talk is to look at time. If people, the astronomers in the crowd will say, the light and the stars we see in the sky happened a long time ago. And so I think the best place to start is in the past. And we'll go look at the past first, then look at the present, then look at the future. Okay? So in the past, when I started as an oncologist, people would tell me about the golden days where they used to use hormone therapies to try to treat kidney cancer. And there's been a lot of studies looking at that, and there's really no evidence that they play a role. So I won't get into that they don't show any benefit. So then chemotherapy is what the majority of medical oncologists like myself do in the cancer clinic, and that's the mainstay of treatment for many of our cancers. However, in kidney cancer, if you use any one drug against kidney cancer, the response rate, or the odds that we're going to shrink a tumor down by more than 30% would probably be only around 6% chance. Okay, and we would not typically take any drug forward to use unless it had about a response rate of 15% or more in chemotherapy. Now, if you start mixing drugs together, there has been some success, and I'll just show up here, there's a drug called gemcitabine and another old drug that's been around forever called 5-fluorouracil, that if you give both those drugs, and particularly give the 5-fluorouracil through a fancy pump, just like a Walkman type pump, and give it continuously, they've actually been able to get a response rate over 15%. But we're looking for much better results than that. And these drugs have side effects consistent with chemotherapy. So I think that's food for thought. And so while I won't say chemotherapy doesn't work, it's not our first option. So it's in our bag of things to use, but we're looking for better things. Well, for a long time, immunotherapy took that role. Now, immunotherapy, there are different types of immunotherapy. The two most common ones that were used, the one we used in Ottawa was a drug called interferon, which is an injection that people would take, usually under the skin 3 times a week. And another version is interleukin-2, which is given through an intravenous infusion, usually in admissions to hospital, usually on a week-on, week-off basis. Now, the problem with immunotherapies is immunotherapies we're using your own immune system to try to attack the cancer. So we know by looking at specimens of kidney cancer that there was lots of immune response around the tumors. As well, some people who have their kidney cancers removed can come back, as Dr. Bro said, possibly 20 years later. What happened for 20 years? Those cells got out, obviously, at the beginning. What took 20 years for it to come back? Well, your immune system kept it under control. So we are using your own immune system to try to attack the cancer, keep it under control. But the problem is when we crank up your immune system, what do you feel like you have? You feel like you have the flu all the time. So these treatments aren't for everyone, and they have a lot of toxicity involved. But the interesting thing is the interleukin-2 one, which some patients, they can melt down or stay stable for prolonged periods of time. So while these drugs have response rates that are in the 15 to 20% range, those are the base minimum we're looking for. It wasn't ideal, but they're still in our bag of tricks that we can try, but we are still looking for something better. So this is the present. This is where we went. So people started to look at the biology of the kidney cancers, and as Dr. Bro mentioned, there's a small minority of patients, only about 5%, have hereditary kidney cancers. Kidney cancers that these people are predisposed to developing. And the most common one is the most common mutation, so this is because of the genes, the blueprints in each one of these people's cells is mutated, and that the gene that's most commonly mutated is one called von Hippel-Lindau gene. And this gene is found in these patients with hereditary kidney cancer, but we also looked at people who didn't have hereditary kidney cancer, and in the clear cells, up to 70% of people had the same mutation. Now, they developed it, what we call sporadically, just by an exposure of some sort. They've developed it. So people started to say, well, what does this gene do? Well, this gene produces a protein that is the brakes for the regulation of something called vasculoendothelial growth factor, a hormone that travels through the blood system that develops blood vessels. So kidney cancers, to grow as large as they do, you're asking about size, how can it grow so big so quick? These cancers put out a hormone that lets it grow blood vessels and grow bigger. And that's what the cancer does. It monopolizes on that. That protein that's supposed to be the brakes on that is broken. And so I think I have a cartoon that shows that. So we like to call these medical diagrams, but other people call them cartoons. But if you look at this, I'm not sure if my mouse will work here. There we go. So here's a cancer cell, and here's a blood vessel over here. Now this is inside the cancer cell. Typically, here's that von Hippel-Lindau protein that it regulates this little protein here when this is another protein within the cell that if you're in a hypoxic or low oxygen state in a normal kidney cancer cell, it would bind with another protein, go down to the DNA, cause the DNA to make VEGF. The von Hippel-Lindau protein says, well, if there's enough oxygen in the system, it would add a bunch of proteins onto it, send it to this garburator, and therefore it would go out the side of the cell and it wouldn't create the excess hormone. Okay, but in von Hippel-Lindau patients, that is broken. And so whether there's enough oxygen in the system or not enough oxygen in the system, it's making lots of this VEGF, and this VEGF goes up here into the blood vessels, tells these lining cells around the blood vessels to start proliferating, growing, so the blood vessels can grow bigger. So essentially, it's an uncontrolled growth of blood vessels by the cancer cells, so that they can continue to grow or go through the bloodstream, spread, tack on somewhere else, and make their own blood supply somewhere else. Okay, so this drug sunitinib, which is one of the first ones that came on the market around 2005, was aimed at blocking. Initially, people tried to mop up the VEGF that's floating around, that's being produced excessively by the cancer cells. And they used antibodies to try to do that. You might have heard of the drug Avastin, which is the trade name, or bevacizumab, which is the generic name. And that showed that there was some slowing of the cancers, but it couldn't really shrink the cancer. So someone said, well, let it make all the VEGF it wants. Let's block the receptor that the hormone works on those cells that line the blood vessel. They have receptors that the hormone binds to stimulate. So someone designed this drug, sunitinib, and what it does is it just blocks the receptor. It can have all the VEGF in the system it wants, it just can't work. And so they showed, so here, each one of these lines is a patient in a study. And this is where they started, and if the line goes down, it shows the shrinkage the patient had. So you can see in this study that this is the line for response rate, 30% shrinkage. It showed that probably almost half the patients had significant shrinkage. So we went from shrinkage rates of 6% with chemotherapy to 15% with immunotherapy. We're now talking 40 to 50% shrinkage with this drug, which is a pill a day. Okay, so this revolutionized. So there was two drugs that came out around that time, sunitinib and another one called sorafenib. And they both performed in the same way. Both came on the market at the same time, and it revolutionized the management of kidney cancer. And again, these are kidney cancers that have spread already. Most treatments in oncology come in and are used when in patients that the cancer has already spread, so we can show that it shrinks the cancers, and then we start moving the treatment into other areas of treatment of cancer patients. So this is in the metastatic setting. These drugs came apologize. And so the interesting thing is, we focus in cancer treatment so much on shrinkage. Everybody loves to see tumors shrink, but the interesting thing we saw with these patients is we just didn't see shrinkage. So you can see here, sorry about the, okay, you can see here that this is a CAT scan, much as Dr. Breaux explained to you. You're looking from the patient's feet towards their head. This is the liver in a patient. And here's another picture of the liver in the patient after they've taken Sutent. And you can see the tumors here have gotten much smaller. So there's a tumor there. There's another tumor there. They're much smaller. And here you can see this is the lung. You can see a white tumor there, a white tumor there. They've shrunk down quite dramatically. But the other thing we see is, here's a different patient. These tumors didn't get any smaller. But you can see they've gone from lumpy, bumpy, dense looking to this is like water. This is changed to a consistency of water. So the tumors aren't shrinking, but they're just liquefying. So we're cutting off the blood supply to the center of these tumors, and the tumors just die from the inside. So rather than using chemo, which is very toxic and like a poison, we're just cutting off the blood supply to the cancer. And we're having to re-look. So anytime I get a CAT scan report, I can't just trust on the size of the tumor. I actually have to look at the pictures, and I actually have to talk to the patient, right? Because the patient says, I feel so much better, and I'm looking at this, and the tumor is actually maybe even a centimeter bigger, and I'm like, and then I look at the pictures, and it's quite obvious that the tumor has responded quite well. So it's again, we're having to change the way we're assessing our response rates in these tumors. Now, the other thing we have to learn is there's new side effects. Traditional chemotherapy, everybody thinks losing hair, nausea, vomiting, all these other things. Not with these targeted therapies. These targeted therapies, the most common side effect is fatigue. Now, it's very variable between patients, but it is sometimes problematic, and we have to make significant adjustments. High blood pressure, we're clamping down on blood vessels, we're clamping down on everything. we start to see it's like taps in the house, right? Start clamping down on blood vessels. It's like if all the taps are on the house, you start turning some taps off, the pressure goes up in the system. So we have to watch hypertension. Diarrhea can be an issue. We have to learn how to counsel patients on how to manage their diarrhea. And they get this unique hand-foot syndrome. I have a picture of that to show you. And then the immune suppression everybody thinks about with chemotherapy is uncommon, and rarely do we see infections and infectious complications like we see with chemotherapy. So here's a picture of the hand-foot syndrome. People get very irritated, sort of red hands and feet, and if they let it get too far, you can actually start having skin breakdown, like on the person on the left, it starts getting cracking, and on the right, you see actually a big callus forming on pressure points. So as Mary explained, we have to tell people to not wear their high heel shoes anymore. We have to tell them to moisturize twice a day, both hands and feet, anytime you wash your hands. You have to learn a new lifestyle of how to manage your side effects while you're on treatment. Another interesting side effect, you don't lose your hair, but your hair turns gray on the treatment. And in fact, because Sutent is given 4 weeks on, 2 weeks off, when they're on the drug, their hair turns gray, and when they're off the drug for 2 weeks, their hair goes back to the original color. And so they could sometimes get a zebra effect in their hair. So it's an interesting side effect. So this is what we call VEGF, so the vascular endothelial growth factor receptor, so VEGFR targeted therapy. So Sutent went on to do a big study, what we call a randomized study, where we give half the patients the Sutent and the other half the patients the current standard, which at that time was interferon. And it showed, again, 3% of people completely melted the tumors away. 44% of people, it was what we call a partial response. Another 40% of people, stable disease. So we love to shrink tumors, but holding them steady is as good a response for us. Because really what we're looking for is, are we making people live longer? And it proved in that study that we do make people live longer. So in that study, that population of patients, we improved survival by about 5 to 6 months. So both the progression-free survival, so they were on that drug till they had to stop the drug because the cancer started growing again. It improved at 6 months there. And then in the long term, after they can move on to other treatments, their survival was also increased. So survival in these patients is great. I mean, we're making gains. And that was just with the first drug. Okay? And you can see now, there'll be a test on this at the end. Okay, the red boxes are the drugs that are starting to come out. So here is the sunitinib and sorafenib drugs blocking a receptor on the blood vessel cells so that they can't be stimulated. Here's the bevacizumab that would try to mop up the VEGF. And you're seeing now we're starting to move into here, and we're getting some other drugs, a drug called everolimus blocking a protein inside the cancer cell that regulates a lot of these other proteins. And here's another one, temsirolimus. That's another one. So they're starting to expand the compendium. And if you can look at, we have a timeline. You can see that there's the immunotherapies back in the 80s, early 90s. And then we had a little gap, and then in 2005 we had sunitinib and sorafenib. Shortly afterward, temsirolimus. Bevacizumab, the antibody, actually started to show comparable responses if you mixed it with the interferon. But again, the toxicities are fairly significant, so it's not a home run hit. Not a lot of people are looking at that. Mary was mentioning pazopanib, which is another VEGF receptor blocker, has come out. It's no better than Sutent, but it has a different toxicity profile. So some people find it easier to be on that drug. And then everolimus, which blocks an intracellular one, came out. And then there's one missing here, a new drug that's just come on the market called axitinib, which is another VEGF blocker. So what we end up with is this kind of grid now about what our options are. And this grid, I'll just sort of see if my little lines come up here. There we go. This is what, if someone presents to us with advanced kidney cancer, that treatments are their treatment, that drugs are the main first treatment of choice. We will try to look at some clinical characteristics about the patient. And so there's a scale that originally was developed by Dr. Motzer, who did the Sutent study, and updated by a Canadian, Dr. Danny Hang, who's in Calgary. He's updated the scale and takes some very simple things. It looks at how long is it between the patient had their kidney cancer diagnosed and they developed metastatic disease. Is it immediately, or is it 10 years? Because someone who's taken 10 years, there's obviously better biology that if it's a more slow-growing process. We're looking at how fit is the person? Are they up and around and have no symptoms versus someone who comes in a wheelchair? It looks at some lab abnormalities that they may have. We're looking at whether their calcium level is a little up. Are they anemic for any reason, and so forth. And we take those things and we can stratify people into whether they're what we call favorable or intermediate risk. So those are the people who have better prognostic factors, or someone who has, X's for all those categories. And we'll pick their treatment based on that, because the studies were geared towards those different populations. So for the majority of people, this is the box where we start. Either it's Sutent, or sunitinib, or pazopanib, otherwise known as Votrient, or bevacizumab interferon, not typically used in Canada. Might be an option. You might see some people talk about being used in the States. Then there's some highly selected people that we might still try the immunotherapy up front, because we don't know who the best ones are, but someone with young, very low bulk of disease, who's very fit. The problem we have right now is the Ontario government cut us off from funding that, because it's a very expensive upfront intervention that we usually were sending people out of country for, because you need specialized centers to do that. Or we were also sending people to Montreal for that. We never offered that in Ottawa because we didn't have the setup in Ottawa. So there's a fair number of options, and then we come down to here looking at once someone has gone through the top box and has moved on, they need to move on to what we call second line therapy. We have more options in the second line, which is axitinib or everolimus. Those are the two drugs I mentioned previously. So we've gone from having maybe 1 or 2 options to 5 or 6 options in 2 different lines of therapy. Okay. So what are the current hot topics? So, clinical trial. There's a Dr. Bjarnason who's based in Toronto who looked at his patients who are on Sutent and said, wow, there are some people who get no side effects, and there are some people who get tons of side effects. And when people get tons of side effects, we start playing around with things. Either it's the dose or the schedule, or trying to make it tolerable for the patient. But he started to look at it and say, hang on, these are the people that never had any side effects, and these are the people that we had to make adjustments. And he noticed that people who didn't have to have any adjustments to their dosing sailed through the treatment. Actually, their what we call progression-free survival, the time till the drug failed, was very short. So the people who had to have their dose reduced or had toxicities actually did better. So maybe, because it's one size fits all with this drug, everybody gets the same dose, maybe we need to dose adjust for each patient. And so he's proposed a study, which Ottawa's participating in. And what we do is we always make sure the patient has a toxicity. Not a bad one, we want to keep it very low grade, but if someone has, 75% of people have to have their dose. So this is an algorithm, and I don't expect people to follow the whole algorithm. And it drives my research assistant crazy when we have patients on this study, because we monitor people very closely every 2 weeks on the study and are adjusting their doses like crazy. But all the doctors in Canada are following the same algorithm, and we're doing a research study to try to show this principle that the doctor in Toronto has identified. And what we're making sure is if someone has toxicities, we all dose reduce in the same way, systematically, and that if someone has no side effects, we start to increase the dose, in fact. And so we're doing this in a research protocol. And we're trying to get every single patient that we possibly can onto this till we hit their accrual thing, and try to show that we can get even maybe better numbers for Sutent if we followed this algorithm. So this is kind of the current hot topic du jour for us, for patients starting on Sutent here in Ottawa. Another hot topic is drug access. And I'm not sure if patients, Kidney Cancer Canada probably has, I should have vetted the website before I came here, probably has some explanations of the system, but I'll just give you a brief overview in that when a drug is finally proven to work, the drug company takes it to Health Canada, so that would be up here, and submits it to Health Canada to say, I want to sell this drug in Canada. And there's usually that process can take up to 1.5 years or 2 years sometimes for a drug to make it through Health Canada to say you can sell it in Canada. So Sutent and sorafenib did that actually in record pace, because there was, it was revolutionizing kidney cancer. There was seen a need, and it came through the system fairly quickly. So Health Canada will let them sell it in Canada. So at that point, people can buy it, or private insurers can fund it. But most people, this drug is $8,000, Sutent or sorafenib are in the ballpark of $8,000 a month. cannot afford to pay for that. And many insurance companies, even if you have insurance, there's a fairly large copay. So a lot of people are looking for provincial funding, your OHIP card to pay for it. So OHIP, or whatever provincial funding agency, will want an economic analysis done. And that is done, so all the provinces said, well, we don't want to each be doing this individually and getting different answers. So there's a pan-oncology drug review, one board that does it for all the provinces and says, how much does this drug cost and what's the cost effectiveness, what's the bang for the buck? And they come up with an answer to say, do they think it's worth the dollar, and usually it comes up with a dollar per life year gained. And that's a dollar amount that you can compare between diseases. So there's a dollar per life year gained for neurosurgery, which is one of the most cost effective because it gains a lot of years in young guys who bash their heads off their motorcycles. If you save them, you get another 60 years out of them, so your bang for the buck is very good. Kidney cancer treatments are very expensive, and the life year gains, the survival gains are not as big, but they've been shown to be cost effective. And so Pan-Oncology Drug Review does that. So even if they say it's cost effective, then it has to go to the province. So that takes another year, and then this takes another year. So you could possibly see anywhere from 2 years to 4 years before a drug showing the effectiveness in the study can actually make it to where OHIP's going to pay for it. So I just wanted to give people a sense that there's probably 3 levels of hoops to jump through before I can write this script for you using an OHIP coverage. And it's frustrating to everyone, and Kidney Cancer Canada has been very proactive in it's trying to speed up that process as much as possible. And now, I'm just hearing that the Pan-Canadian Drug Review, the economics, is now being done in parallel with the Health Canada submission. So you're not doing it sequentially, you're doing it in parallel. So we're hopefully going to save time and make some gains in that. Okay? So I hope that gives some sort of insight. We have a surgeon in the room. I thought I better talk surgery. I have no surgery pictures, sorry. But I thought I would talk a little bit about surgery and metastatic renal cell carcinoma. So kidney cancer is one of the few cancers that even if the cancer has spread, sometimes we take the original cancer out. Okay, most cancers, if it's spread, we don't take the original, we just treat it all with a systemic therapy, something that a medical oncologist might give. But in kidney cancer, there has been some data that shows if we take the primary cancer out, there's a survival benefit. Now that was in the days of immunotherapy, and so generally we only do it now is if it represents the bulk of your cancer, so you might have small other disease, but you have a large primary tumor, we would take it out. We'd also want to make sure that the patient can tolerate the surgery, because we don't want to do a surgery that would diminish the person's quality of life. And people who aren't fit may actually not tolerate the surgery very well and may not get to my treatments, which is really the treatment they need. So it's very selected patients. But here in Ottawa, we're participating with the help, so it's a teamwork. We're participating in a study that's coming out of Europe that's re-asking the question, do we really need to take the kidney out? So the study is looking at taking patients who are fit to have this surgery and randomizing, flipping a quarter, to see half the patients we do the surgery as we would normally do right up front, and the other half the patients we give them Sutent for about 3 cycles, 3 times 6 weeks, so 18 weeks, and then we take a break, and then we take the kidney out. And they're saying, let's see if there's a difference if we delay the surgery. And maybe we don't need to do the surgery in a lot of patients, and re-ask this question again. So it's just an interesting question. This is another clinical trial that we have in Ottawa that we're participating in. And then Mary beat me with her story of people who have their kidney cancer taken out. Should we be giving these new fancy drugs right after to prevent the cancer from coming back? So they've done it with immunotherapy. It was negative, the studies. Chemotherapy's never proven it. But now with these drugs, we've participated in 2 trials here. So the first one had the first 2 drugs that were on the market, sunitinib and sorafenib, and we gave patients a year's worth of that. So 1,500 patients from around the world went on that study, finished accrual about 2 years ago. We're waiting for the answer. Right? We have to watch these people for years to figure out, was it the good thing to do? There was an arm in that study who also got placebo. So placebo versus treatment for 1 year. There was a second study, which is the one Mary participated in, where it was placebo versus pazopanib. And again, for 1 year, we just finished accrual on that one. That was another 1,000 patients went on it. So hopefully we're going to have an answer for both those studies within the next 2 or 3 years as to whether we should be giving these drugs after surgery to prevent or delay recurrences. And so now we're on to the future. So those are the hot topics and the questions we're answering today, but where are we going in the future? So I showed you that we are blocking the receptors. All these R's down here are all the receptors. We've designed lots of different drugs that selectively pick off all these different receptors. We've also shown that we can block this enzyme that's inside the cell with a drug, everolimus, I was showing you there. But now they're moving higher up in the hierarchy here, and there's a whole bunch of new code-named drugs that they're trying out, and hopefully these will pan out. But the most interesting ones that are coming out is we're going back to immunotherapy. Immunotherapy is making a comeback, but in a different way. So rather than just indiscriminately cranking up your immune system using these hormones that we were giving, they're looking at actually targeting the T cells. So there's different types of cells in the immune system, but targeting the T cells in the system, or possibly using vaccines to try to treat kidney cancer. So here's another medical diagram, otherwise known as a cartoon, showing that here's a T cell that hang out in your lymph nodes. They're usually primed by a different type of immune cell with what we call an antigen, and that T cell goes out and looks for the cancer cell and tries to attack it, right? Because it recognizes the cancer cell as not normal. There's something, it's not a normal cell, and attacks it. Fortunately, the cancer cells have learned, there's an off switch on T cells, this little PD-1 thing here. And the cancer cells have learned to flick that off switch. And so they have designed now antibodies to block either the off switch or block the cancer cell's finger that sticks out to turn the off switch. And so we're testing these, and these have actually shown activity, testing them in multiple different types of cancer, not just kidney cancer, lung cancer. And then, in fact, there are drugs on the market now for this stage of T cell, of blocking the off switch at the initiation point. Melanoma, we have a drug that's on the market now in melanoma, ipilimumab, that goes and blocks that system, blocks that off switch, keeps the immune system cranked up, and melanoma is another cancer that's has great potential to be controlled by the immune system. So this is the future. So it's kind of like Michael J. Fox, Back to the Future again. So here we go. We're going to bring immunotherapy back. Okay. And here's just an example of a vaccine where that big green blob up on the left, they prime it specifically with information about the patient's cancer. So they take cells from a patient's cancer, prime that little green blob that was up in the corner, dendritic cell, and expose it to the T cells and re-inject it as a vaccine to the patient's T cells. And so hopefully have a specific immune response to an individual's cancer. And so this study actually is just rolling out now, and the lab that's going to make the vaccines is actually going to be based in Canada. For East Coast North America, possibly is going to be based in Montreal. And so we're hoping to participate in this study as well. So that's a lot of information. Hopefully I didn't lose people too much, but keep it simple. Metastatic renal cell carcinoma is treatable. It's very treatable. We have lots of options now. And that access to the novel treatments remains a critical issue, and participating with Kidney Cancer Canada is probably your best way to help move this forward, and learning how to advocate, because there are many other tumor sites that don't have as many advocates and don't get as many drugs. Kidney Cancer Canada has leapfrogged other tumor sites and is doing great. And then if you can participate in clinical trials, it's key to helping answer important questions and move the science forward. And Ottawa is actually viewed as a leader in kidney cancer